So continuing our series of BCQs, and this is going to be part 3. So first question, 50 years old man with idiopathic interstitial lung disease is discussed at MDT. It is decided that a tissue diagnosis is required to confirm the diagnosis before initiating a treatment. Which interstitial lung disease can be mostly reliably diagnosed with transbronchial lung biopsy? So this question is asking which ILD disease can be reliably diagnosed with a transbronchial lung biopsy. Is it desquamative interstitial pneumonia, IPF, lymphoid interstitial pneumonia, NSIP, or sarcoidosis? All of these diseases could be diagnosed with a biopsy, but the most reliably diagnosed one would be, and the answer is sarcoidosis. Sarcoidosis is the interstitial lung disease that can most reliably be diagnosed with a transbronchial lung biopsy. Transbronchial lung biopsy is a procedure in which a small piece of lung tissue is obtained through a bronchoscopic inserted into the airways. It is less invasive approach compared to surgical lung biopsy. Sarcoidosis is often present with the granulomas in the lung and other affected organs. Transbronchial lung biopsy can be useful in obtaining a lung tissue sample for histopathological examination to confirm the presence of non-caseating granulomas, which is a hallmark of sarcoidosis. Next question. 25 years old fit and well female present to her GP with 3-month history of breathlessness. She has a regular exercise capacity but gets episode when she suddenly feels the urge to breathe quickly. She also described the sensation of not getting enough air into her lungs. She has no other respiratory symptoms and her examination is normal. What is the subsequent most appropriate investigation? ABGs, axial nitric oxide measurement, incremental cardiopulmonary exercise test, Nijmegen questionnaire, or serial peak flow measurements. Answer is, given the description of patient's symptoms and the clinical presentation, the most appropriate investigation would be Nijmegen questionnaire. The Nijmegen questionnaire is a screening tool used to assess whether a patient might be experiencing an hyperventilation syndrome or dysfunctional breathing. Hyperventilation syndrome can present with symptoms like breathlessness, rapid breathing, sensation of not being able to get enough air, and other vague respiratory symptoms often triggered by anxiety or stress. The questionnaire helps to identify the patients who might have a dysfunctional breathing pattern that are contributing to their symptoms. Next question. 87 years old woman referred to the respiratory clinic with progressive shortness of breath over many years. She is a lifelong non-smoker with no history of respiratory disease. She has severe osteoporosis and has suffered several wedge fractures of her spine. On clinical examination, she has a severe kyphoscoliosis. The cardiovascular and respiratory examination is unremarkable. Spirometry reveals a moderate restrictive defect. ABGs, pH 7.47, PaO2 7.9, PCO2 6.5, bicarb 30. What is the most appropriate management? So there's an 87 years old lady who had a progressive shortness of breath. She is a non-smoker, but she has some restrictive defect secondary to kyphoscoliosis. and osteoporosis. So appropriate management. Commence on a long-acting beta-2 agonist inhaler. Commence on CPAP. Refer for a corrective spinal surgery. Repeat blood gas in 4 months or start a trial of BiPAP. And the answer is the ABG results and the clinical information suggest that the patient is experiencing a chronic respiratory alkalosis characterized by high pH and low PaCO2. Chronic respiratory alkalosis occur in condition with the prolonged hyperventilation leading to excessive elimination of carbon dioxide from the body. Given the patient's history of severe kyphoscoliosis, wedge fracture of the spine, and progressive shortness of breath, it is likely that a respiratory alkalosis is a result of chronic hyperventilation due to her spinal deformity and decreased lung volume. This is known as a respiratory failure, and the most appropriate management for this patient would be to start BiPAP, also known as a non-invasive positive pressure ventilation. Bilevel ventilation is a form of mechanical ventilation delivered through a mask and can help improve ventilation and oxygenation in patients with ventilatory failure due to conditions like kyphoscoliosis. Next question. 48 years old lady referred for the investigation of suspected sleep apnea. She struggles to concentrate and sleepy during day, so she has fallen asleep at work and nearly crashed her car after falling asleep at the wheel. During overnight polysomnography, frequent apneas are observed. How long must ventilation cease to be considered an apnea? So this question is basically asking a definition of apnea. 3 seconds, 5 seconds, 10 seconds, 15 seconds, or 20 seconds. And the answer is 10 seconds. In the context of sleep apnea, apnea is defined as a cessation of airflow for at least 10 seconds. This means that the person's breathing is stopped for 10 seconds or more during sleep. The frequent apneas observed during overnight polysomnography in the described scenario likely contributing to patients' symptoms of daytime sleepiness and impaired concentration. Next question. 32 years old woman who is 4 months pregnant develops sudden onset chest pain and increased shortness of breath. She presents to accident and emergency where a limited perfusion scan reveals evidence of left-sided pulmonary embolism. Which of the following is the treatment of choice for a pregnant woman diagnosed with a PE? Catheter-directed thrombolysis, inferior vena cava filter, low molecular weight heparin, unfractionated heparin, warfarin. So this is a young lady who is pregnant and has PE. Treatment should be. The answer is the treatment of choice for a woman diagnosed with a pulmonary embolism during pregnancy is low molecular weight heparin. Pregnant women with pulmonary embolisms are at increased risk due to altered hemodynamics and increased coagulation factors during pregnancy. Low molecular weight heparin is the preferred anticoagulant for treating acute venous thromboembolism in pregnant women because it has been shown to have a relatively lower risk of adverse effect on both the mother and fetus compared to other anticoagulants. Next question. 50 years old man referred with a daytime sleepiness and poor concentration. He has a history of hyperlipidemia. On examination, he is obese with a large neck circumference. His EPSS EPOT score is 16 out of 24. Polysomnography confirms the diagnosis of Severe obstructive sleep apnea. Which of the following is a physiological consequence of OSA? Hypotension, increased catecholamine release, insulin sensitivity, increased parasympathetic nervous system activity, reduced right ventricular preload. Physiological consequence of OSA. And the answer is increased catecholamine release is a physiological consequence of OSA. OSA is characterized by repeated episodes of partial or complete upper airway obstruction during sleep, leading to brief awakening, disrupts sleep architecture, and decrease oxygen levels in the blood. These episodes of apnea and hypoapnea triggers the body physiological response, including sympathetic nervous system activation, increased catecholamine release, specifically adrenaline, epinephrine, and norepinephrine is a common consequence of OSA. The intermittent hypoxia and arousal from sleep during apnea events cause a surge in sympathetic activity, leading to increase in catecholamines. This can result in various cardiovascular effects, including increased heart rate, vasoconstriction, and elevated blood pressure. Over time, these cardiovascular effects can contribute to the development or exacerbation of hypertension, cardiovascular disease, and other related complications. Moving with a second question. 32 years old man presents with a 3-week history of shortness of breath, cough, and hemoptysis. He also has a generalized joint pain and fatigue and report a nasal crusting and epistaxis. He has never smoked, no previous history of respiratory disease, blood tests show an ESR of 86, hemoglobin of 108 gram per dl or 10.8 milligram. C-ANCA anti-PR3 is positive. Renal function and urine dipstics are standard, they are normal. Chest X-ray shows a bilateral alveolar infiltrates. Pulmonary function tests show a raised KCO 130. What is the diagnosis? Eosinophilic granulomatosis with polyangiitis, EGPA. Giant cell arteritis. Goodpasture syndrome. Granulomatosis with polyangiitis, GPA. Microscopic polyangiitis. So this question is really about a diagnosis. A young male with shortness of breath, cough, hemoptysis, epistaxis, nasal crusting. C-ANCA is positive with pulmonary bilateral alveolar infiltrates and KCO raise. I think it's a clear-cut diagnosis of granulomatosis with polyangiitis, previously known as a Wegener's. Granulomatosis with polyangiitis, GPA, formerly known as a Wegener's granulomatosis, is a form of a small vessel vasculitis that primarily affects the upper respiratory tract, lungs, and kidneys. It is characterized by necrotizing granulomatous inflammation and vasculitis involving small to medium-sized blood vessels. The clinical presentation in this patient including shortness of breath, cough, hemoptysis, joint pains, fatigue, nasal crusting, epistaxis, and the presence of positive C-ANCA is suggestive of GPA. The chest X-ray findings of bilateral alveolar infiltrates and a raised KCO, diffusing capacity of the lung for carbon monoxide, are also consistent with pulmonary involvement seen in GPA. Moving towards next question. 50 years old Caucasian male present to acute medical intake with the painful raised swellings on both shins. On the direct questioning, he reported minimal dry cough but no breathlessness. Chest radiograph is requested and your opinion is sought. The chest radiograph shows a bilateral hilar lymphadenopathy but no parenchymal infiltrates. There is no history of previous TB and he has never traveled to endemic area. Her serum ACE is markedly elevated, 109, and a tuberculin skin test is negative. Complete lung function including static lung volumes and gas transfer factor are expected. What is the most appropriate action? So in this question, you have to make a diagnosis and then decide about treatment. Is it an urgent dermatology review to biopsy the skin lesions before starting on PRED once daily? Is it prescribe NSAIDs for erythema nodosum and reassure the patients there is no indication for a specific treatment but there is a need to follow up in clinic? Initiate anti-tuberculous medications for suspected primary TB infection? Reassure the patient, give simple analgesia and discharge? Start prednisolone 40 mg once a day for a diagnosis of sarcoidosis presenting as a Lofgren syndrome and follow up in clinic. You can pause the video, think about the diagnosis and write your answer in comments so you can compare with the correct answer. And the correct answer is the most appropriate action in this scenario would to start a prednisolone 40 mg once daily for a diagnosis of sarcoidosis presenting as a Lofgren syndrome and follow up in clinic. Lofgren syndrome is a specific subset of sarcoidosis characterized by acute onset bilateral hilar lymphadenopathy, erythema nodosum, painful raised swelling on the shins, and sometimes joint pain. Elevated serum ACE level is also consistent with the diagnosis of sarcoidosis. Lofgren syndrome prognosis is generally good and a spontaneous resolution can occur over time. However, symptomatic corticosteroid treatment can help to alleviate the symptoms and speed up recovery. The chest radiograph finding of bilateral hilar lymphadenopathy without parenchymal infiltrate in combination with clinical presentation and elevated ACE levels strongly suggest a diagnosis of Lofgren syndrome, a form of sarcoidosis. Therefore, starting PRED and following up in the clinic for monitoring and potential adjustment of the treatment would be the most appropriate course of action in this case. And the correct answer is this. Next question. 18 years old man with non-Duchenne muscular dystrophy is seen in respiratory outpatients department because of deterioration in breathlessness. An echo 6 months ago revealed mild LV systolic dysfunction with an EF of 45% and no valvular pathology. His symptoms worsened when he lies flat and takes a bath. On examination, he is comfortable at rest with an average heart rate, respiratory rate and oxygen saturation of 94% on room air. He has normal heart sounds, no raised JVP or peripheral edema. His chest expansion is symmetrical, percussion node resonance, and his lung fields are clear to auscultation. In early morning blood gas revealed mild, fully compensated respiratory acidosis. Which investigation is most likely to diagnose the cause of his worsening breathlessness? So young, 18 years old with Duchenne muscular dystrophy, coming with breathlessness. And the question is which investigation should be done to find out the cause of breathlessness? Chest radiograph, CT pulmonary angiogram, echo, peak expiratory flow rate, or ratio of supine or seated force vital capacity. It's a very good question. regarding a Duchenne muscular dystrophy or extrapulmonary restrictive disorders. So you can take some time. And the correct answer is, given the patient's history of Duchenne muscular dystrophy and his worsening breathlessness, the most appropriate investigation to diagnose the cause of his symptoms is the ratio of supine and seated forced vital capacity. Patients with the Duchenne muscular dystrophy often develop respiratory muscle weakness over time, leading to decreased lung function and increased risk of respiratory complications. The supine standing FVC measures the change in lung function when moving from a seated to a supine position. In a patient with Duchenne muscular dystrophy, a reduction in ratio can indicate respiratory muscle weakness that affects their ability to maintain lung volume while lying flat. This change in lung function can lead to symptoms such as worsening breathlessness, especially when lying down. You can comment in the comment section that how much FVC should be reduced. Next question. 55 years old obese lady with new onset non-atopic asthma sees you in clinic. Her asthma control test score is low, 10, suggesting poor disease control despite of high dose of inhaled corticosteroids and a long-acting beta agonist. She is frustrated that she is not responding to therapy. What would be the most appropriate advice when counseling her about her disease? It is unusual for an obese woman to develop asthma later in her life. Patients with this phenotype generally have fewer symptoms and better disease control than other asthma phenotypes. There is no link between obesity and asthma. This phenotype tends to respond well to inhaled corticosteroids. Weight loss has been shown to significantly improve disease control and symptoms. So this question is basically asking a relationship between asthma and obesity. So your knowledge, if you know anything about asthma and obesity. The answer is, the most appropriate advice when counseling an obese patient with a new onset non-atopic asthma would be weight loss. Has been shown to improve a disease control and symptoms significantly. Obesity can contribute to worsen asthma symptoms and poor response to treatment. There is a well-established link between obesity and asthma. Studies have shown that weight loss can lead to improved asthma control, reduced symptoms, and better response to medication. Obesity-related factors such as increased inflammation, altered lung mechanics, and reduced lung functions can exacerbate asthma in obese individuals. Next question. 85 years old lady comes to see you in the clinic with shortness of breath. Her GP has requested a lung function with FEV1 of 85% predicted, FVC of 95%, FEV1 to FVC ratio of 66%, and the gas transfer of 95. Based on the lung function, GP is concerned about she has an airway disease. When reviewing a lung function in elderly patient, what should you consider when interpreting the results? The gas transfer factor does not decline with age. Residual volume increases. Spirometry become increasingly obstructive. Spirometry become increasingly restrictive. Total lung capacity reduces. So this is asking age effects on lung functions. And the answer is, when reviewing a lung function in elderly patients, it is important to consider that spirometry tends to become increasingly restrictive with age. As a pupil age, Their lung volumes can change due to a variety of factors including changes in chest wall compliance, respiratory muscle strength. These age-related changes can result in a reduction in lung volume measurements such as FVC and total lung capacity. This is often reflected in spirometry results as more restrictive pattern. DLCO can also decline with age due to changes in lung tissue and blood vessel function, but this decline is generally not as significant as the changes in spirometry measurement. Residual volume may not necessarily increase significantly with age, and spirometry does not typically become increasingly obstructive in the absence of specific lung disease. So the answer is spirometry becomes increasingly restrictive with age. Next question. 73 years old men with IPF commenced on nintedanib 18 months ago. Despite tolerating the treatment and having few side effects, his symptoms of cough and breathlessness continued to deteriorate. According to NICE guidelines, treatment with antifibrotic agents should be discontinued if FVC decline in 12 months is greater than 2%, 5%, 10%, 25%, or 50%. I think this is an easy question. And the answer is 10%. Next question. 72 years old man has just been diagnosed with IPF. He is keen to know more about his long-term prognosis. What is the median life expectancy from diagnosis? So this is a question about IPF. Is it 1 to 2 months, 6 to 12 months, 2 to 3 years, 5 to 10 years, and 10 to 20 years? And the answer is approximately 2 to 3 years. Next question. 35 years old male is trekking in Nepal. He couldn't sleep well the last few nights and wake with a dull headache and nausea. He is also a little breathless, but it is determined to continue his trek to Annapurna Base Camp, 4,130 meters. After further ascent the next day, he developed a cough and shortness of breath at rest, forcing him to stop. What is the most appropriate treatment? Acetazolamide, dexamethasone, nifedipine, oxygen and descent to a lower altitude, stop at current altitude and rest overnight to allow acclimatization. You can take your time, and the correct answer is the most appropriate treatment in this situation is oxygen and descent to a lower altitude. The individual is experiencing symptoms consistent with acute motion sickness, a condition that occurs in high altitude due to lower oxygen levels. The symptoms of AMS include fatigue, headache, nausea, shortness of breath, which can progress to more severe conditions such as high altitude pulmonary edema or high altitude cerebral edema if left untreated. In this case, the person has developed symptoms of cough and shortness of breath at rest, which could be indicative of HAP, which is in high altitude pulmonary edema. The best action is to provide supplemental oxygen to alleviate this hypoxia and descend to a lower altitude as quickly as possible. Oxygen therapy can help to improve oxygen sats and relieve symptoms, while descending at a lower altitude is the most effective way to resolve altitude-related symptoms. Next question. 60 years old man attends the respiratory outpatient clinic to review the progress of his IPF. Due to his low FVC, he does not meet the criteria for antifibrotic therapy. In the clinic, he asked his doctor whether he would be a candidate for lung transplantation. When considering a lung transplantation in IPF, which of the following is a significant contraindication? So this question is basically asking IPF patient lung transplant contraindication. Is it biventricular heart failure, BMI of 30, portal hypertension, osteopenia, renal cyst on ultrasound scan? Significant. The question is about significant contraindication. So the major contraindication is biventricular heart failure. Others could be there, but the significant is biventricular heart failure. Next question. 63 years old man present to his GP with worsening breathlessness, abdominal swelling, and peripheral edema. He is on warfarin following a large unprovoked pulmonary embolism 18 months ago. He is referred urgently to cardiologist to diagnose significant pulmonary arterial hypertension with signs of right ventricular failure on echo. A CTPA reveals a large organized saddle pulmonary embolism in keeping with CTEPH diagnosis. Which of the following is the treatment of choice for CTEPH? So this is asking about CTEPH treatment. Balloon pulmonary angioplasty, calcium channel blocker, pulmonary end arterectomy, Rossiger sildenafil. And the answer is pulmonary end arterectomy. Pulmonary end arterectomy is a surgical procedure used to treat CTEPH by removing the organized blood clots that have become lodged in the pulmonary arteries. It is the most effective treatment options for CTEPH, especially in cases where the disease is operable. The procedure can significantly improve pulmonary hemodynamics, alleviate symptoms, and improve the overall quality of life. And that's it. Happy learning. Try to subscribe channel and comment as well.